Thanks, Dr. Chow. Okay, good morning, everyone. Thanks for tuning in. I know during the summer month, things are busy. So thanks for welcome everyone who's here and who's online. In picking a topic, as you know, there's lots of topics that are already on the YouTube channel, and we thought what we would do, and this was with the help of Rudy, one of the other Echo fellows who showed me this article and helped with some of the slides, is that we would review a little bit about why we do dynamic testing in patients with hypertrophic cardiomyopathy in terms of provoking an LVOT gradient, and also as it relates to this journal article. So the title of the journal article is called Unmasking Obstruction in Hypertrophic Cardiomyopathy with Postprandial Resting and Treadmill Stress Echocardiography. We picked it because it's a topical paper. It just came out, as you can see, and it's not even in full print. So it came out at the end of June. And it's kind of something interesting, it's novel, and I hadn't heard about it. And it came out in a reputable journal, the American Society of Echocardiography. So the objectives for the day, we're going to review the role of stress echo and hypertrophic cardiomyopathy. This is all something we do. It's part of our protocol. Why do we do it? Why is it important? And then what's the relationship between postprandial straight and LVOT gradients? Because when I first heard of this, I said, what the heck? How are they relevant? Why does it matter? And then that will kind of segue into reviewing the journal article, its findings and conclusions, and then hopefully there'll be a little bit of time to discuss if it applies to our lab and then to the people online as well. So just a bit of the outline, we're going to go through hypertrophic cardiomyopathy, the echo findings, the role of stress echo, postprandial stress echo, the journal article, and then a bit about just a discussion. So hypertrophic cardiomyopathy, as we've all have seen, so just to review the definition, basically it's left ventricular hypertrophy in the absence of another cardiac, systemic, or metabolic disease. So, for example, if your patient has hypertension, that wouldn't count here. And basically, they're capable of producing a magnitude of LV wall thicknesses in different patterns. And while we've identified many genetic etiologies, some are still unclear. So in terms of the prevalence, why does this matter? It's 1 in 500 patients in the US, and that includes asymptomatic patients. And that's really important, and that's especially here because we're trying to identify an obstruction in asymptomatic patients. And then symptomatic ones / diagnosed patients are estimated to be less than 1 in 3,000. Clinically, they're very different, and you guys have all probably seen. Some are extremely symptomatic, some wouldn't even know it. It's just kind of an incidental finding, and that just represents the varying phenotypes. There's not a distinct cookie cutter idea of how HCM is in terms of patient populations, in terms of ethnicity or sex pattern distribution. And so these studies provide a lot of insight because it helps kind of identify groups that we might be missing. So basically 30 to 60% have a genetic variant, but many don't. And so that is important, and it can sometimes help diagnosis, but not always. Sorry. Let me try to go to the next slide. Oh, there. Okay. Sorry about that, guys. Okay. So when you're diagnosing it, and if for the sonographers in the room, for the clinicians in the room, you're referred, what are the things to keep in mind in terms of differential diagnosis? And for the residents in the room, this is a common question that comes up on exams. So there's acquired and secondary causes of increased wall thickness. So hypertension, as I prior mentioned, athlete's heart, amyloidosis, sarcoidosis, acromegaly, and less commonly seen hemochromatosis. And then there's also metabolic conditions that are less commonly seen. Fabry's is one actually that I actually saw quite a bit living out east, just because there's a founder effect in Nova Scotia. But other ones include glycogen storage disorder, Danon cardiomyopathy, and some mitochondrial myopathies. Dr. Chow is big on history, and I think it's great because it helps us see why are we here? How did this come to be? So First published descriptions of asymmetric hypertrophy actually date back to the mid 1800s, which is kind of crazy when you think about the differential for this, and that people were able to find and kind of zone in on this being a topic. And so it was published in a French journal here. And what they reported was various case reports of enlarged hearts, increased muscle bulk. And what's relevant to us and in the echo world is obstruction of blood flow through the left ventricle into the aorta. And then eventually there'd be degenerative changes and fibrosis. And so this is the article, and these are just a couple of quotes that were translated. It was published in French, and so. But some of the things that were mentioned and found out in the patient group were the symptoms we often see: palpitations, syncope, and then pathology was found that. There's severe LVH. It may or may not fit a certain pattern, and it results in the outflow obstruction. Back then, what was really kind of zoned in on, because there was a lack of imaging, and was the physical exam. And what this group of physicians found, and as you all know, that's in terms of there was the murmur, which was pre-systolic, that was clear. Secondary heart sound was not very distinct. And so that was the start of what we now know as HCM. And this is a gentleman, Dr. Paul Wood, from the National Heart Hospital. And so basically over the next 50 years, from what we first have seen in some patients, he kind of helped zone in on formal diagnosis, and help kind of getting together a better understanding of this condition. So just a little bit fast forward. So now we're in the mid 1900s, and what we have from advances in medicine is we have better pathology and pathologic findings to correlate what we've seen on physical exam, and now what we can now see in terms of echo. So Dr. Donald Tier was a famous pathologist in London who published a landmark case series in the British Heart Journal. And this detailed cardinal features of hypertrophic cardiomyopathy, summarizing symptoms, ECG findings, echo, and as well the pathologic findings. And so just a quick review on that, because I know this is an echo talk and not a path talk, but the pathologic findings that you'll see here in these three. So you'll see localized hypertrophy of the interventricular septum. That's number A. B is disordered muscle fibers varying in size. And C is abnormal anterior mitral valve leaflets. So you can kind of see, these are things we see on echo, well, rather the latter, the microscopic views. And so now this is becoming more and more a thing. Pair that with the introduction of echo. And so between the 1960s and the 1990s, we start correlating the findings with echo findings, the physical findings and the clinical findings. So there was an improved understanding of the pathophysiology and the SAM of mitral valve, thanks to M mode and 2D color Doppler flow. And then just to kind of tie this back into clinical and what we see with our patients. So now we can better diagnose it with imaging. What do we do? And in the 1990s, alcohol septal ablation was first done in London at Brompton Hospital to try and help patients with their symptomatic HCM. So here's just an echo clip. So in 1995, Robert Levian, Arthur Wyman, and his colleagues highlighted abnormalities in the mitral valve apparatus leading to SAM and LVOT obstruction. So as we probably know, but just to review, there is anterior displacement of the papillary muscles. There's leaflet elongation and altered coaptation, decreased tension and increased slack of the chordae tendae, allowing for drag forces that pull the valve anteriorly into the LVOT, the left ventricular outflow tract. So this is just an MRI. So anatomical features and HCM pathology, which we sometimes see in echo and can be better corroborated on MRI, is that LVOT obstruction occurs in 70% of patients with abnormal mitral valve apparatus and septal hypertrophy. The anterior movement of the leaflet leads to a posterior directed mitral regurgitation jet. And then this obstruction, well, why do we care about it? Does it matter? Because sometimes we do it on patients, we get them to Valsalva, we provoke it. Why does it even matter? And then it matters because for a couple of things. So one is symptoms, so patients can get angina. There's increased wall stress and oxygen demand, which over time affects the metabolics of your heart. LVH and myocardial fibrosis eventually leads to diastolic dysfunction. So the idea is by hopefully identifying this obstruction, whether it's at rest or with exercise, we can help identify patients that are more at risk of having long-term sequelae of their HCM. Okay. So just a little bit more of things we might see leading up to it in terms of identifying. So arrhythmias, a couple different reasons patients can get arrhythmias with HCM. Diastolic dysfunction results in elevated LA pressures, and that a dilated LA is more prone to developing atrial fibrillation. LVH, basically the hypertrophied muscle results in myocyte disarray. And that is scar tissue. And as we all know, scar tissue doesn't conduct electricity normally. It's disarrayed, it's architecturally different. And that's what predisposes these patients to VT, VF, and sudden cardiac death. Syncope, and that's an interesting one because it could be due to the ominous arrhythmias that I just described, or it could be due to their left ventricular outflow obstruction. And then, of course, dyspnea. And I think the biggest thing that I've seen throughout clinical training is patients just don't feel well. And some of these patients are quite young and they say, I used to be able to chase after my kids and go for walks and I just can't. And that's why it clinically matters, which I think is important because we can sit here and talk about gradients and valves and this thing and that thing, but coming back to the patient, this is why it matters. Okay, so let's go back to imaging and how does imaging help? Because we can have symptoms, we can have ECG findings, and echo is a great first gateway tool, and MRI can often be used as an adjunct. So just to remind us of the definition, HCM is any segment greater than 15 millimeters anywhere in the ventricle without an alternate pathology. So that's, they don't have hypertension, they don't have Fabry's, they don't have sarcoid. Typically, you can see 13 to 14 millimeters in first-degree family members with HCM. And that's why it's really important when you come across this to ask about screening family members. Genetic testing can also be helpful too. And it can be important because once a gene is identified, you can then test genes in family members and look to see if they might go on to develop the phenotype. The presence of left ventricular outflow tract obstruction is not required for the diagnosis, but as you guys probably know, we make a point in differentiating the two, HCM with obstruction, without obstruction. And that's because it has, as we're going to talk about, clinical relevance, but the obstruction is not needed to make the definition of HCM. Okay, and so just a couple more slides on the management, and then we're going to get to the trial, I promise. So the management, and this is relevant because you might scan or come across patients that are on some of these treatments, and it's important because it should factor in, and do they have an obstruction in the setting of these treatments? So that also matters too. Have we tried anything? So for symptoms, the common go-tos are beta blockers, calcium channel blockers. The guidelines say disopyramide. We didn't, in our center, that wasn't commonly prescribed, but that is an agent. Myosin inhibitors, so these are the new kids on the block, mavacamten. And then septal reduction therapy. And so this is if patients continue to be symptomatic. And the big thing that matters is the LVOT obstruction significant? And I'm going to keep harping on this, but this is why this study is so important because it gives us a tool to help prove that obstruction is significant. If patients have AFib, they're anticoagulated, regardless of their CHAD score. Lifestyle modification is important. And if there's a history or risk or high risk factors for sudden cardiac death, these patients could qualify for an ICD. Okay, so the echo, the meat. So LVOT gradient. So it's measured using the CW Doppler, and traditionally, the classic teaching is it's a dagger-shaped profile. It's a dynamic obstruction, and it worsens with systole. And for those of you, just to clarify, you can see on the right, dagger-shaped Doppler, exactly as Dr. Chow was pointing out. And I think that's really important. And for everyone in the room, and I remember when I was going back to when I was learning, differentiating aortic stenosis from an LVOT gradient, this dagger shape can be really helpful. And that's really important. So that's why that's brought up there. What's considered a significant gradient? Because some of these patients have gradients, and what matters? 30 is the number to remember, at rest or provoked. It doesn't matter if it's provoked. And I think that's important because, sometimes we focus on rest, but patients go out and live their life. And if they're doing things and they're experiencing these gradients, it matters. Gradients over 50 is typically a threshold for septal reduction therapy. Again, so with our study in Postprandial, if we're able to elicit a higher gradient, they could be eligible for further treatments. Okay, so a third of patients present with a resting LVOT, obstruction, and then a third of patients you have to provoke it with maneuvers. Identifying the presence, so why does it matter? And I've kind of alluded to it. It's essential because it's not just about treating symptoms, but it's about preventing future sequelae and quality of life. Quality of life is a really important thing patients will tell you. Okay, so this is probably familiar to a lot of us. So when we're imaging patients or even in the clinical setting, we can do certain maneuvers to try and accentuate the LVOT gradient. So the pathophysiology behind this is you're trying to basically reduce the preload or reduce the afterload or increase inotropy. And so the idea is a smaller ventricular volume worsens the obstruction. The Valsalva strain phase is important, and some other things. So what are some things you can do? You can get them to Valsalva. You can do squat to stand. You can use nitrates, inotropes, or as we commonly know, you can get them to exercise. Okay, so stress echocardiography. Why do we do it? Why is it important? As we've kind of alluded to, it's a way to bring out a gradient in patients that say I have symptoms, but we don't see a gradient when we do a normal echo, or when we do an echo at rest. It helps identify patients that are at risk for sudden cardiac death. We can tailor treatment. Normal Valsalva-induced velocities do not exclude outflow obstruction. And so 50% of such patients will generate gradients with physiologic exercise. Valsalva-induced velocities underestimate exercise gradients by 20 to 65 millimeters of mercury. And that's really important because we can get them to Valsalva while we're echoing them. But if it's underestimating it by 20 to 65, well, remember 30 is the cutoff, remember 50 is the cutoff for intervention. We could completely be missing a group of people that we could intervene on. So that's why stress echo is so important in this population. It's to uncover occult LVOT obstruction, accessing for dynamic MR, and ultimately treatment. And you can just see here in this JAG article the importance of identifying patients, and in terms of how many people are exercise echo in terms of provocable obstruction, and the ones that you actually do get people that are able to, you get symptomatic that go on to have medical therapy, the drug refractory ones that end up getting septal myectomy or surgical myectomy. And so it's just identifying patients that we're missing. That's the take home point. Okay. So, what do we do? And I think this is why it's kind of helpful, and it's great. It would be great at the end to have patients or people from other labs kind of weigh in, because there's no currently widely accepted or standardized protocol. And every place does it a little bit differently. The key fundamentals are you have standing exercise, and standing imaging is proposed as more physiologic than supine. And in the study that we're going to talk about, that's exactly what they did. Imaging recovery is also important because post-exercise decrease in ventricular return is often associated with accentuated gradients. So these are the different kind of proposed ideas and about what we could do in terms of how we evaluate for different levels of obstruction. And so I think the common one, or at least the one that I was trained with, was you perform a CW across the LVOT and measure the peak gradient, document the heart rate, and then go on from there. And then you do this pre-exercise, and then you do this post-exercise. It's important to note that medical therapy should not be withheld prior to the testing at the physiologic response while taking the therapies is important. And that's why when you're encountering patients or you're scanning, it's important to know what are they on, or if they've had any medical treatment in the past, did they take it or was it held prior to scanning them in the morning. And then so post-exercise, again, there's a variety of things, but the big thing would be to perform it just like when we do stress echo, performing it as quickly as possible from the time imaging begins, and to go from there. So yeah, there's a variety of things in terms of proposed ideas in terms of how you could do this algorithm. Okay, and then where does this fall into the guidelines? So the 2024 ACC guidelines recommended that exercise echocardiography in symptomatic or asymptomatic patients without resting gradients as a class 1 recommendation. So it's actually very important. And I wonder, and this is just, I don't have any data to back it up, but I wonder if we're kind of underutilizing stress echo based on this. Now, you have to keep in mind, this is an American journal. They have more access to echo, but class 1 is pretty significant, and so it's definitely something to keep in mind. So when we talk about postprandial, we're talking about so the journal study said postprandial increased gradients. Why does that matter? So postprandial mean after patients have had a meal. What is the pathophysiology behind this? So the idea is that after you eat a meal, there's a decrease in systemic vascular resistance from mesenteric vasodilation. So just because it had been a little while since I remember exactly the anatomy. So that's the anatomy on the right-hand side. So you can see the mesenteric artery comes right off of the aorta and heavily supplies the large bowel. There then is an increase in adrenergic stimulation, which then results in increased contractility. So that's the idea behind this. How did this come to be? Like, what had been done prior to this? Where did we get this idea? So interestingly enough, observational studies date back to the 1990s, and they identified that approximately a third of patients experienced postprandial increased LVOT. The obstruction was thought to be due to a variety of stressors, and at that time these were just observational, and so they thought, okay, could it be meal related? And the idea was it does favor LV obstruction and supports the idea that patients can have symptoms postprandial. And I'll admit, this is something I never ask my patients when I'm seeing HCM patients. I never ask, do you have them? But this was something that was identified. So one of the studies that I thought was good at kind of really, and it's a very small study, but I think it was a pivot to the study we're going to talk about today, was this study. And so it was 20 patients. And basically what they did is they detected latent obstruction who were not normally obstructed after the usual provoking factors or exercise. So these were patients who said, I have symptoms. We went and sent them for a stress echo. We couldn't get anything. We tried maneuvers, couldn't get an obstruction. And then they said, okay, well, let's see what happens 1 hour after lunch. Now, lunch was not standardized. It was just, they just said eat a moderate size amount. And within the first 3 hours, they had their echoes. They had one before lunch and then they had one after lunch. And interestingly enough, and I'll show you the actual images, but 13 of the 20 patients had a higher gradient. And the mean gradient was 83 compared to 34 in the patients that didn't. And so there's a nice schematic, and I apologize. Oh, it's actually not too small. So what you're seeing here is the different. So on the top left, you see the fasting supine gradient, and then you see the standing. On the right, you see the standing gradient. So nothing too crazy in terms of difference. And then you see a post-exercise supine gradient. That's kind of all pre-eating. And then if you come down to the bottom, that's when you really start to see some changes. So postprandial rest supine. Then they get them to stand. See, you can see a bit of an increase. And then post-exercise, postprandial. Okay, sorry, it's quite a few steps. But what this is really just showing is the extent of how we can take it even further in terms of bringing out a gradient. And so just so that you can kind of see, just so you have some numbers there, in the postprandial group on the left, postprandial rest supine, that gradient was 58. In the standing, the gradient was 92 millimeters of mercury. And in the post-exercise, postprandial, it was 161. So we've just, and again, very small study, but this got people thinking, hey, we could be onto something in terms of increasing, unmasking significant gradients. Okay, so finally at the study. So this is what prompted this study. So the objectives were to examine the value of postprandial resting and stress, and then to have us get a sense of could it help us utilize invasive or enhanced drug therapies, i.e. could we target treatment based on what we're finding in this study. And then what they wanted to do is, so the idea was we'll take HCM patients without LVOT obstruction, and we'll do a routine echo, postprandial echo at rest, then with exercise, and see if we can bring about an increased gradient. So study population, and this is always important because it kind of says, does this population that was captured here apply to the patients we see on a day-to-day? So patients were greater than 18 years old. They had to have a wall thickness of greater than 15 millimeters or greater than 13 millimeters with a family history. No LVOT obstruction or at rest, but they had symptoms either with exertion or postprandial. So symptoms included chest discomfort, lightheadedness. The ones were pretty classically known, arrhythmias, syncopes, but they also included dyspepsia. And this was the first time I was hearing of that, and in terms of as being asked. But if patients have dyspepsia postprandial, that was an inclusion criteria. They also included patients with a history of surgical myectomy, valve repair, or septal ablation. And I found that interesting because I think at the end of the day, they just want to know who patients are symptom, regardless of if they've had treatment or not, is there still a gradient? Exclusion criteria included mid-ventricular obstruction and patients who had an apical aneurysm, because the spectral Doppler evaluation of this phenotype typically underestimates the true magnitude of the obstruction. So this is the demographics in terms of the patients and their population. A couple of things to note. As always, women are underrepresented, 38% there. The age was kind of younger-ish, 57, and I think that's important because, as we have elder populations, it may not apply as much. In terms of, so then you have the usual risk factors. I think what's also important is their NYHA class status, and there was a pretty good representation. Obviously, you can understand why NYHA class 4 wasn't included, just because of the frailty and the other complications. And then what was also interesting, I found, was that 20% of them had an ICD at the bottom there. And then if you go over to the right of the right table, you can see what percentage was on medical treatment. So interestingly enough, 85% were on a beta blocker. So we tried to medically treat them. 43% were on a calcium channel blocker. Even though they included patients with prior surgeries or interventions, it was a very small part of that population. So also important to remember. Okay, so what was the intervention? How did they do this? So postprandially, the patients would get on a treadmill and exercise to evaluate the possibility of a latent LVOT obstruction. Their resting echo, they'd have a resting echo and then they'd have a postprandial echo. Their resting echo, what was defined as fasting, was 3 hours. And it just included your classic rest images and stress echo images. And then they also tried to provoke gradients using maneuvers. So basically what we do normally for an HCM patient was the baseline echo. Then they ate a meal. And this is a bit ambiguous because they basically just said a moderate size meal. And what did they use an example? They said a sandwich with a cookie. So a lot of heterogeneity there. Anyway, postprandial stress echo was obtained 30 to 40 minutes after. And again, the same protocol that happened preprandially happened postprandially. So you get to rest, you do exercise, and then you try and provoke with maneuvers. Interestingly, patients, and as we know, they did not take negative inotropic medication. So they actually stopped their medications prior to this testing. So they could have been 85% were on a beta blocker, but they didn't take it when the echo images were acquired. So just some nuts and bolts about exactly what they did. So the sonographers captured post-exercise with a continuous wave Doppler to measure the LVOT gradients. Then the mechanism of obstruction was known. Post-exercise imaging was continued in the supine left lateral decubitus position. And then the following things were assessed: continuous wave Doppler, looking for SAM, and then left ventricular wall motion. Okay, so this, I apologize again if it's a little small, but this kind of goes through the patients and then how they got to the final group in terms of those that had a significant gradient. So 252 patients without LVOT obstruction were referred for this study. In terms of the ones that were actually included, it was slightly less, and basically 239 had a gradient less than 50, and actually 13 had one already over 50. Then, out of that 239, routine Valsalva was done. And so you can see there that identified a subgroup, 15%. Has a significant gradient, but there were still 84% that didn't bring it out. So those 84 went on to postprandial testing. So they had the meal, 30 to 40 minutes later, we test them. The first thing is just let's do an echo postprandially. And already 13% were identified to have an increased, a significant gradient. So just eating alone, 13% were identified. Okay, then we try and do maneuvers and see, okay, would that identify more? Another 14% were identified. But still, there are 151 of those 203 patients that didn't have a significant postprandial gradient. So we do one more thing further, and we say, let's exercise them postprandially. And this is where you get the biggest bang for your buck, and 25% more patients are identified. So if you sum up all of those, because technically they're all postprandial at rest, postprandial with maneuvers, and postprandial with exercise. If you sum up that, you're identifying 35% more patients that have a significant gradient. And that was the kind of hallmark of the study in terms of what postprandial measurements can do. Okay. So I kind of went over this, but just a little bit more about the statistics. So among the 252 patients where postprandial LVOT gradients were higher or were measured, at rest the median was 9 versus 0 millimeters of mercury. And then with provocation, it was 18 versus 1.5 times. So these are times. 49 patients achieved greater than 50 millimeters of mercury under routine conditions. 90 additional patients, that's what I said, that 35%, achieved postprandial gradients greater than 50. And then there was another subgroup that 15% was with postprandial stress alone. So that's trying to see, okay, of the postprandial, what's important, and it was 15% of those 35%. A total of 71 patients were treated with 91 invasive or enhanced drug therapies. 32 of them had a gradient of greater than 50. So what that means is there's treatment implications of these findings. And then they did a subset analysis, and what they looked at was postprandial exercise gradients were higher in 44 patients who underwent both postprandial and fasting stress echocardiography. And so there's here. So this kind of just puts everything together that we've talked about. So you had 252 patients initially who did not have a gradient. They underwent, and then 49 of them had a gradient on routine echo at rest or provocation. And then 90 patients postprandially together, 38 of them with exercise. And I think that's important because what this study is trying to do is it's showing that it's not just enough to do postprandial. You have to do postprandial with maneuvers, and you have to do postprandial with exercise. It's used in conjunction. And then 56% of the patients were treated with invasive or enhanced drug therapies and who had a postprandial gradient greater than 50. Okay. And so this basically is looking at how the patients that we identified, how their NYHA class changed over time with the addition of medications. And I think it's important because it again comes back to why is this clinically relevant, and it's because patients were then able to be started on drugs that affected their NYHA class score. So that's that. In terms of a couple of limitations to the study, so it was retrospective, and the stress echo postprandial were taken at a separate time point than the rest echo. There was a time lag. And so when you kind of think about, or some of the critiques of this study, there's not too many, but just because it's so new, but one of the thoughts is, well, from the time they had their rest echo to the time we did their postprandial, maybe there was a change in clinical status. And maybe the gradient we're identifying has nothing to do with the postprandial state. It's just that their clinical status has changed. The other thing was that in terms of external validity is that this was done at a single center that specializes in HCM. It's a tertiary care center, and then it's an academic center. And so it's hard to say if you're at a smaller center that doesn't have as experienced sonographers or clinicians in terms of HCM, could you reproduce these results with the postprandial protocol? Hard to say. And it was not a study, interestingly enough, of all non-obstructive patients. So they identified, and you could kind of argue maybe they cherry-picked patients in terms of the ones they thought would have issues or thought would be identified with postprandial. And that comes back to that inclusion criteria. They had to have exercise-induced symptoms or postprandial symptoms. It wasn't just let's take every patient that doesn't have an obstruction and measure them. The meal was not standardized, as I explained before. And the type of Valsalva maneuvers were also not standardized. So it was kind of up to the discretion of the sonographer. And as we know, there can be some differences in terms of efficacy of the different maneuvers. Okay. So just to conclude the study, and then I'll kind of open up the floor for some discussion, is what does this what have we learned so far today? So LVOT obstruction in patients with obstructive HCM can be challenging to provoke. And we know we can exercise them, we can do maneuvers, we still don't get a gradient, but we have a very symptomatic patient. Postprandial echo in this study, again, I don't want to generalize it to everyone, in this study, unmasked LVOT obstruction in a third of the patients that were classically presumed or labeled as non-obstructive HCM. Half the patients went on to be treated with therapies, and eating before, and I think it was at least clear to me that eating before resting and exercise echo could be a powerful tool in unmasking patients with obstruction. I think there are challenges, obviously, in terms of adopting this, just because you need to be experienced, but it could be something that in a few years' time, with some more traction, becomes a protocol in future labs.